Welcome to the 4th Annual Lecture on Aging. I'm Renee McGovern. I'm chairperson of the KCOM Committee of the Geriatrics Initiative across our university. And we have our friends in Phoenix with us online. We need more volume? Okay, is that better? All right, thank you. We have our friends in Phoenix at the Arizona School of Health Sciences online with us and this afternoon, and the Dentistry School are joining us in this lecture. It is with great pleasure that I'm able to introduce our speaker, Sue Ellen Levkoff, Dr. Sue Ellen Levkoff. Dr. Levkoff comes to us today from beautiful New England, where she's an associate professor of psychiatry at Brigham and Women's Hospital and the Department of Social Medicine at Harvard Medical School. Dr. Levkoff completed a bachelor's degree from Wellesley College, an MSW from New York University, a master's in health services administration, and a doctorate in behavioral sciences from Harvard School of Public Health. Dr. Levkoff was principal investigator and project director for the groundbreaking multi-site randomized trial on primary care research on substance abuse and mental health for the elderly, the PRISM-E study, which she will talk about today. I have personally known Dr. Levkoff best in her role as the director of the Positive Aging Resource Center, or PARC, a technical assistance and education center for evidence-based behavioral health care for older adults, where our own Kirksville program, ElderLink, was nurtured. I found her to be compassionate, informative, helpful, and inspiring, and it's just been so delightful to be able to bring her to Kirksville. Dr. Levkoff served for 20 years as the director for the Harvard Upper New England Geriatric Education Center, and she was president of the National Association of Geriatric Education Centers. She is currently the editor for Aging International and author of over 100 peer-reviewed journal articles, book chapters, monographs, and books, including most recently Evidence-Based Behavioral Health Practices for Older Adults, A Guide to Implementation, Aging Well, The Complete Guide to Physical and Emotional Health, and Aging in Good Health, 3 very wonderful books. Dr. Levkoff is an amazing, hardworking scholar. I'm feeling like I'm a total slug being with her. She works so hard and is committed to improving our knowledge and understanding and our care for the elders in our country. We are just very privileged to have her here today. Thank you, Dr. Levkoff. Please help me welcome her.
Thank you. I'm the one who's honored to be here. And after listening to that, I wish that my mom were still alive to hear that, because, you know, she would be so proud. Thanks, Renee. I'm going to be talking on the study that she mentioned, the PRISM-E study. And when we started out in the field about 8 years ago, we knew from the literature that there were substantial mental health and problems with alcohol problems among older adults. And older people were not getting the care. Older people don't get the care that they receive for their mental health problems. And I know that you're learning about this in some of your courses now, and so you know that there are many reasons for this. There's a huge amount of stigma about admitting to have a mental health problem for the current generation of older people. And so there's really an unwillingness to admit that they have one and to go seek care. And also from the provider system, there are also barriers to care there, because providers, like you're going to be, the providers haven't been trained in providing mental health care for older people. And even though there are guidelines that are available, they really aren't currently used in practice. We also know that the majority of older people, when they do try to seek care for their mental health problems, they go to the primary care system, and they don't go to the specialty referral system, again, because of issues related to stigma. So when we started out the study, we looked at the state of the field, and we recognized the prevalence of these problems, the fact that they're not getting the care that they need, the fact that they are in the primary care system to try to get the care when they do seek help. We looked at the field, and we realized that there were several studies that were ongoing, and the adults who, and the people in those studies, the adults who sought care in integrated service systems had better clinical outcomes than those, who sought care in traditional specialty referral settings. And there were two major studies that were ongoing at the time that we started our PRISM study, and one was Prospect and one was Impact. And both of these studies compared collaborative care for older people in the primary care system, where a mental health provider, not a psychiatrist, but a mental health provider, a master's trained social worker, or a advanced practice nurse, were in the primary care setting providing mental health services in collaboration with the primary care physician. And those studies compared that model of care to usual care, which was sending them out to the specialty referral system, and oftentimes people never even got there because that's the major breakdown. A primary care doctor makes a referral and the patient never gets there. So the two major studies at the time showed that collaborative care in primary care resulted in significantly better outcomes than referral to the specialty care, which was usual care. We didn't want to repeat that study. So what we did was we chose to implement a study where we compared collaborative care in primary care to the best possible enhanced referral system. So that's a major difference, and as you see me talking about the study, it's important to remember that, and I'll talk to you about the differences in what our study, and what we provided, and you'll see that as I go through these slides. But that was a very important difference in what we were proposing to do compared to the impact and prospect studies that were conducted at the same time and whose results came out shortly after. So our overall study goal was, under which conditions are the integrated or enhanced referral models for behavioral health care most effective in terms of access to care, and that's actually getting to the first visit, just initial access to care, and adherence to care, whether it's prescribed medications or with treatment, patient outcomes, depression symptoms, as well as alcohol, problems with alcohol at risk, and seeing the symptoms for reduced drinking, and I'll talk about that later, as well as cost outcomes. So the study was funded by SAMHSA and the VA and HRSA. We had 7 sites that were, we had 6 sites that were funded by SAMHSA, one of which was actually a VA site. So we had 5 sites that were non-VA sites and 6 sites that were VA sites. And you'll see the breakdown in the actual demographics when I show that later. It made for a very interesting sample. 2/3 of the participants were male because of the heavy preponderance of VA settings that were included in the study. And I wanted to have a geographical picture of this, but I couldn't find one. But you can see that it's, there were sites all over the country, from California to New Hampshire, 3 in New York, 2 in Pennsylvania, Arkansas, Florida, and in Madison, Wisconsin. 2 of the sites were also additionally funded with HRSA funding because they were community health centers. It was a very complicated project. Rather than a typical project where you apply, you have a grant, you get funded, and then you implement your grant, the way this was, people applied for an initial planning grant, and at the end, and then the sites that got funded for the planning grant then had to go through a year of working together to actually change what they said they were going to do in their planning grant to come up with a common protocol. This was a really complicated, this was really a complicated process. And in terms of research, one really doesn't hear about the difficulties in getting research into the field. One sees the results and you see the splendid differences in outcomes between groups, but people don't really talk about the difficulties that go into producing those large randomized trials. And this was really difficult for this particular project. We had, first of all, in terms of in terms of all the different agencies that were involved, we had SAMHSA officials, and you can see here for the federal representatives, we had people from CSAP at SAMHSA, which is prevention. We had people from CSAT, which is treatment, as well as CMHS. So we had 3 different kind of heads, leading people who had given money, who wanted to see that treatment, prevention, and services delivery were going to be examined. And then we had our program managers from the VA who wanted to make sure that their questions got answered. And then we had the HRSA administrators who also wanted to make sure that the issues relative to the underserved were answered. So we had many, many chiefs that we had to respond to. So we had the chiefs from the federal level, and then we also had the chiefs from the individual site PIs who were also trying to, the PIs who got funded had all been very accomplished in their own fields, had all been used to doing things their way, used to using their own measures, used to using their own special preferences for the research process. So all of a sudden, we would have these meetings, and Dr. McGovern would come to other meetings for this other project that we were a part of, but there were the same kind of meetings. We'd have all of these leaders, all of these very well-known physicians, well-known physicians in the field coming together, and I'm a non-physician, I'm a social scientist, and I'm leading these groups for the coordinating center, and I'm trying to get these people to come to consensus and say, well, maybe your way of doing this is okay, but mine's better, but yes, I'll give in to you. So it was just the process of research is something that's really complicated. And when you're dealing with people who've accomplished a lot in their own lives, and they're used to doing it that way, it's difficult to get people to decide to do it differently for the overall common protocol. So a lot of what this project involved was negotiating with these individuals to try to get people to come to consensus and agree on how to promote this common protocol for a randomized study. And so this is just a list of committees that we developed groups of people, because every decision we had to go through this consensus process to kind of come to a decision about what the protocol was. What were we going to, if you looked at the literature on integration of mental health, there are all kinds of different ways you can integrate. We chose collaborative care, collaborative co-located care, which I'll talk to you about. But other kinds of integrated care can mean a training model where the primary care provider gets trained to do the mental health treatment, him or herself, and does it that way. So we had to make all of these decisions, and all of that was done through committee work. And this right here is just an example of the committees that were involved with trying to make decisions so that we could implement the study. And if you can imagine what some of these meetings were like, people would really come to blows with each other about decisions and how to move forward. One of the best ones was we also had SAMHSA is very committed to consumer involvement in research. So we had 5 consumers that at each year they rotated, but any year there were 5 consumers who were very involved with all of the decision making. So they would come to all of the large meetings where these decisions got decided. And trying to involve consumers in this very sophisticated kind of randomized trial research where you have to ask questions time and time again of patients, so the questions become like a 2-hour interview where you say in your informed consent you're going to talk to people for a half hour. So we used to have caucuses, like with the political caucuses, where the old people, we would take them outside to kind of explain, well, this is why you have to do it this way. And they'd look at us and say, well, you know what, you don't have to do it this way. You asked us to be here, and we don't think you should do it this way. And so we actually made changes that one wouldn't normally make in the so-called, randomized trial, an efficacy randomized trial. But this was really translational research in the community. This was really health services research in community settings where you didn't have all the finances to help maintain that kind of rigorous control. This is the real world. And so the consumers, as difficult as it was to go through those decision-making God, I don't even know what you'd call them, but as difficult as that process was, it really did improve, it improved significantly the quality of the research. And typically we don't do that, but this was translational research. So the study involved, there were 11 study sites, as you saw from that earlier slide, but each of the 11 study sites had several clinical sites where they provided care affiliated with them. So we actually had over 50 primary care clinics and referral mental health clinics that were part of our the sites that we were implementing the services at. And at each site, patients were screened for mental distress, and we used the GHQ for that, which is not a specific, doesn't come up with a specific diagnosis, but we used it for screening to see who was distressed, and then we went down to assessment for specific diagnosis. We screened for mental distress, suicidal ideation, and at-risk drinking. And those who screened positive for any of those conditions went on to be assessed for the target conditions for the overall study, which were depression, anxiety, and at-risk drinking. So patients who met the target conditions were randomized to integrated care or to the enhanced specialty referral care. Within, this slide is not completely accurate. It's within these treatment arms, the study sites had a large degree of freedom in administering a treatment related to depression. So we didn't mandate that clinicians follow guidelines for depression because, again, it was translational research. This was research in the community. We didn't want to impose some kind of artificial service delivery on them that they weren't going to do in the real world. So we allowed them to practice to treat their patients as they would normally treat them for depression. But we did mandate for the common protocol a common treatment for at-risk drinking. And the common protocol for at-risk drinking was the brief alcohol intervention. So everyone did receive the same treatment for at-risk drinking, but the physicians were free to practice to treat their patients for depression and for anxiety as they would normally treat them. And again, as I said, there were many ways to define collaborative care, integrated care. Our major distinction was that the mental health or substance abuse service was co-located within the primary care setting, physically co-located right there. The primary care provider worked collaboratively with the mental health specialty, the mental health or substance abuse specialist in a team approach. And the mental health substance abuse specialist here, as I said earlier, was typically a master's prepared mental health social worker or an advanced practice nurse. And the sites had to have at least 6 months of experience in administering integrated services so that we weren't going to have kind of a ramping up. We weren't going to be looking at outcomes as they were ramping up for integrated care. We want to make sure that they had been doing this for a while. The enhanced specialty referral model mostly was what you think of typically. It's you send one somewhere to a specialty referral setting. And the psychiatrist, the specialist providing the care, was typically the psychiatrist, not the lower level person, so that's a big distinction. And so the psychiatrist had the primary responsibility for providing the care. Again, it was at a specialty care setting, so it wasn't co-located, it wasn't in the same setting. And the referral was for all consumers in the referral model. And it was important that it also be well-functioning. So what we did was we mandated that rather than have usual care like the other studies had, we mandated that they were going to be well-functioning specialty referral care. So basically, our real question was, we don't want to look at integrated versus usual care. We want to say, if you have the best integrated model and you compare that to what good referral care could be, what really good, well-functioning referral care could be, what are the outcomes then? So that was really our difference in focus from the other studies. So in terms of our program enhancements, this is what we made sure these were implemented at all of the specialty referral settings. All patients were referred to their setting within 2 to 4 weeks of their primary care appointment, so that they weren't going to just disappear and not get there. Another requirement was that transportation was available to and from appointments. And one of the community health centers that got funding from HRSA, they used that money to actually purchase a van so they could take people back and forth to the referral appointment. We also made sure that people didn't not get care because they weren't covered. So the grant money actually facilitated coverage for the cost of mental health and substance abuse treatment. We also made sure, and this was really important, that there was a follow-up phone call to patients if they missed their appointment for referral. Because we know from other research that people get referred and they just don't go, and that there's no follow-up. And we also, obviously, there had to be some process in place for emergency or urgent consults if we actually found someone with a problem. So our inclusion criteria were people had to be 65 years or older, have an appointment in a participating primary care clinic, because that's where they were screened. They had to assess positive at baseline for one or more of the target conditions, and also to give informed consent to participate. And I won't go into these exclusion criteria, but people who had a BLESSED score, which is a score for dementia, of over 16 were not eligible for treatment. And certain other diagnoses, people were not eligible, which you can see right here. So again, in terms of the target conditions, we included both major, minor depression, as well as dysthymia and depression NOS. For anxiety, generalized anxiety disorder, panic, and anxiety NOS. And for drinking, we looked at both at-risk drinking and at-risk drinking, taking medications that would poorly interact with them. And here was our generic patient flow chart. But again, they differed somewhat across settings because people, just because of the nature of the different the different centers implementing the project. But there was a screening. The primary care doctors could exclude patients that they didn't think should be followed up. People who screened positive then, and after they were patients were excluded, they had an assessment. Then after that, they agreed to be randomized, and then were referred to the 2 different models of care. Screening instruments are here. The one screen that we used for the VA patients that the other centers didn't have was a screen for PTSD. Here is the list of the measures for the full assessments. The mini international neuropsychiatric interview was used for the major psychiatric disorders. The CESD was our outcome for depression, severity. I don't have to read these, but these were the measures that we used. And again, we had a baseline measure that was within 2 to 6 weeks after the initial screen. And then we had 3-month assessment and 6-month assessment for all of the participants in the study. And the VA actually had money to have a 12-month assessment on their participants. So we screened a large number of people. Over 24,000 people were screened. And again, we found that these data are completely consistent with what are out in the literature, which was good. So we had some kind of validity for what we were finding. That about 20% of the people we screened scored positive for some kind of psychological distress. And again, that was with the GHQ. And 8% had at-risk drinking, and 5% had suicidal thoughts, which is extremely consistent with the other data out in the field. And here are the results for screening with age, which again is very consistent with what was out there. You can see that for psychological distress, the screening rates went up with age, and that for drinking, the screening rates for positive at-risk drinking went down with increased age. And again, this is consistent with what other research has found. Here you see suicidal ideation by ethnicity. And again, this is consistent with the literature that Asian Americans had the highest rate of suicidal ideation in our sample. And we actually, in terms of this sample, the Asian population was really Chinese Americans at one community health center in New York City, the Chinatown Health Center. So that's really, it's really for the Chinese group that we interviewed in New York City. Here you see screening results by, for suicidal ideation, and you can see the impact of having a comorbid major depression and anxiety and how that increased the risks on having, either depression or anxiety alone. It goes from 12% and 8% up to 18% for having both of them together. And you know that as you're studying in aging, comorbidity is a huge, this enormous amount of comorbidity of in older populations for chronic disease as well as for physical disease as well as for physical and mental health illness. Here's a slide showing the baseline characteristics for the sample in the randomized trial. And you can see that there's a preponderance of males, which makes the sample somewhat unique because of the 6 VA centers. It makes it a somewhat unique sample. Also, what was interesting about this was that we were able to include so many people from different ethnic minority backgrounds, which was really unusual, that we have 50% who are white, but we have a large, 50% that are from Black, Asian American, and Hispanic backgrounds. And the mean number of chronic diseases was 5, which is, I think, also fairly consistent with the literature from other studies. 68% had a depression diagnosis, and among these, another 28% almost had a comorbid anxiety. And about 28% had at-risk drinking, and among these, 26% had comorbid anxiety and depression. And 3.5% had an anxiety diagnosis. This was something that we were surprised at because we anticipated that there would be a much higher number of people with anxiety than we found. One of the first studies that we did, one of the first outcome papers that we looked at was initial engagement with care, or initial access to care. And as you can see, the integrated model did significantly better on access to care overall, as well as for patients with depression and alcohol. And this is in spite of the fact, remember, that for our requirement for a well-functioning enhanced referral model, that we made the appointment for the patient to get them to the enhanced referral model, and that we made sure that they would have transportation to get there, and that we called if they missed the appointment. So this is in spite of the fact that we did everything to enhance their ability to get to the model. There was still a much higher rate of access in the integrated model. And here you can see the impact of physical proximity to care, and you can see that in the integrated model. There was a much higher rate of engagement in the in the blue column, and you see with increasing distance from the primary health setting that there's a much lower rate of engagement. You can see from it goes down. So physical distance obviously makes it, is important. In terms of number of visits by diagnosis, you can see that there's a higher number of visits for depression, at-risk alcohol, as well as dual diagnosis in the integrated model compared to the enhanced referral model. We also did a study looking at the attitudes of the primary care providers for in providing care. And this is interesting because the primary care providers, they stated that compared to the enhanced referral care model, they thought that the integrated care model led to better communication between the mental health providers and the PCPs, less stigma for the patients, and better coordination of mental and physical care. But fewer of them thought that integrated care led to actual better management of the conditions, better management of anxiety, better management of the alcohol problems, or better management of the depression. So it's interesting because it seems like they're saying that integrated care was better for the process measures, but not as good for the actual outcome measures, which is interesting to think about. Here we have the major outcome for depression. And I was talking with Dr. McGovern earlier and talking about how the physicians really didn't want to acknowledge these data, these outcome data. And if you look at the data, you'll see that if you look at the bottom, and you'll see that that's for all other depression. There was really no difference in treatment outcomes for the overall sample in terms of CESD scores between the integrated model and the enhanced referral model. There was a significance for people with major depression. So basically what that translates into is that people with major depression actually did better when they went to the enhanced referral care. And when we started out this study, again, the PIs of each of these sites went into this study because they were all very, very committed to the integrated model and to showing that the integrated model worked better. That was the field at the time, and that's what everyone was talking about. So when these data came out, it showed that, in fact, people with major serious depression, they actually did better on the CESD score, which is symptoms. It's symptomatic. It's symptom scores. But they did better in this model. There was a lot of resistance on the part of the physicians to actually go with these data and publish these data. And so all of the articles, if you actually want to go on Google them, you'll see that in these outcome studies, there's a great amount of effort spent talking about why we didn't get the same outcomes as the prospect and impact studies did, which were being published at the same time. But in a sense, what we really felt was, not being a psychiatrist, my feeling was it wasn't a one-tailed study. I mean, it wasn't designed to be a one-tailed study. So it was designed to say it could go either way, the hypothesis. But the physicians, they were committed to this idea that integrated care was best for all. So I think it was a real learning process for us all to realize that, it was not a one-sided test. And in a sense, I think what we were able to come away with is that rather than a one-size-fits-all, some patients can do as well. I mean, some patients need one kind of care. Other patients do as well as in the integrated model. But at the time, about a few years ago when we were publishing these data, the President's Commission on Mental Health was being published. And basically in that report, it said that there should be choices. Older people should have choices for where they want to get their care. And so these outcomes, I think, fit into that report, saying that yes, they should have choices, and our data seem to suggest that choices are important because some people do better in one system than the other. So this was an important outcome. Another way of looking at those data also is that if you don't come in with the idea that the integrated model is definitely better, the other way of thinking about it is thinking, wow, you can get as good of outcomes in integrative collaborative care than you can in the enhanced referral model where everybody is a psychiatrist. It's another way of flipping around the same outcome. Boy, you can do as well in this as if you were getting care from a psychiatrist in the other model. So in terms of our alcohol outcomes, there was actually no difference in if you were in the integrated model or if you were in the enhanced specialty referral model for either of the alcohol analyses, which is reducing number of drinks per week or reducing the number of binge episodes in the past 3 months. But the goods, I mean, that's, you know, there were no significant outcomes. However, look at the data. An intervention, a focus on reducing drinking in the prior week, as well as binges in the prior 3 months, significantly decreased symptoms. Look, from 18% to 11%, the change of 6, from 17 to 11, change of 5. So it's kind of like, instead of saying there were no differences between groups, however, attention to the issue reduced drinking significantly in both study arms. So the message is, maybe there was no difference between using the BAI, the brief alcohol intervention, versus what the specialty referral providers were using in the integrated model and in the other model. So the outcome was still good. You can actually reduce drinking, at-risk drinking. And think about it. These are big drinkers. I mean, look at that. 18 drinks in 1 week. That's a lot of drinking in 1 week. And 20 binges in 3 months. I mean, you know, that's at risk. That's a lot. So both of the models worked in significantly reducing the at-risk drinking behaviors. Now, this is also something that people don't talk about when they do research. But the brief alcohol intervention requires 3 visits to complete the intervention. And you all might know this more than me, but you know, there's a discussion with the provider and the patient, and you know, do you know what your risks are? Has anyone ever asked you? Has anyone ever told you they think you should stop drinking? Have you ever tried to, et cetera, et cetera? And then the patient and the provider, you sign a contract or you do something like that. It's a very formal something. You come back another time, and then you come back a third time. So the actual intervention, you know, requires these 3 visits. And two of our study, one of the study PIs and another person on the project had actually been involved in developing the brief intervention. Fred Blow, who's at Michigan, you know, he and David Oslin went around to each of the study sites and they trained them in the brief alcohol intervention. So, you know, there was training. Everyone knew how to do it. But the fact of the matter is, look how few people got the full 3 visits. I mean, you know, over 40%, maybe 45% only got 1 visit of these 560 people with an at-risk drinking problem. And, you know, maybe 25 people, you know, 20% of people had 2 visits. So here, on this part of the study, we actually did have a guideline-based care. We actually went out and we trained people in the specific guidelines. And we still didn't have, in the real world, people didn't do it. And again, that's something that you often don't see when you report on data in articles, is the process evaluation of what goes on to actually get the data. So I just thought that would be interesting for you. These were just mean responses to patient satisfaction, another paper that we did. And rather than reading all these, I just think the interesting thing is that the 2 that are not significant, the amount of help received and help deal with an emotional problem, which is just so interesting because the process measures they seem to have satisfaction with, you know, got the service you wanted, quality received, you know, would go back again, would recommend. But the fact that the 2 things that were not significant were the help with the emotional problem and the amount of help received is just, don't know. So basically, we did the study. We responded to the fact that there were huge unmet needs. We know that some people are particularly vulnerable. You know, we saw with the screening with the Asian Americans. That's certainly something that would be interesting to pursue. We found higher rates of access and integrated compared to our enhanced referral, comparable rates of the improvement in symptoms for depression overall, but enhanced improvement for patients with major depression. And again, both treatment models helped reduce drinking. And we did find that there was this slippage in implementation fidelity, which is important to point out. We differed from these other studies, as I said. We did not have a usual care arm. We didn't compare it to usual care, as I said. It was enhanced specialty referral. We also didn't mandate the algorithm-based care for mental health treatment. We had a higher proportion of males, again, because of the VA. And we had a very good and high percentage of ethnic minority participants in the study. And that's it for the formal presentation. Thank you.
We have time for questions. Questions? Any questions from Arizona? No questions. Well, I have a question. You talked about the treatment fidelity. Could you explain to us a little bit about what you mean by fidelity and what the slippage? How did you find the slippage? How did you identify that was happening?
A huge part of this study was was looking at the different factors at the local sites that might make a difference in the final project outcomes. So we developed a process evaluation tool, which was probably a 65-page instrument that we went out to the different study sites and we interviewed the providers and we interviewed the administrators at the sites to actually document what they did. So at each site we had information on what kind of treatments were provided, who provided them, what was the level of the training of the people who provided them. We had information on the number of visits. We had information on the number of prescriptions that were written for people to get their meds. And we documented all of that information, and we documented it actually at 2 different times. We documented it at the study onset, and then we documented it again about 6 months into the study, into the data collection, to see if those same, if things were being maintained. If the implementation fidelity is really to see, is the service being delivered according to how it was supposed to be delivered. So we did it at the beginning as well as to see if they continued to do that. And that's when we gathered those data. So we found out that people really weren't getting the treatment that they were supposed to be getting, for the brief alcohol intervention, the fact that so few people were actually getting the full treatment. And I think that actually happens a lot in research, is that it's kind of, the data get published and you say, well, the intervention didn't work. But it's really oftentimes, it's not that the intervention didn't work, it's that the people didn't get the intervention as designed. So that I think this step back into translational research, into documenting how the intervention gets rolled out. If you collect those data, then you can really understand. If you have no finding, perhaps it's because they didn't get what they were supposed to get, and then look for other reasons. So I think there's a real richness in. I think that there's a real richness, and I really do think that the research community is really moving toward this translational research in a way that is going to really benefit the field, because no one has the money to do the research in the efficacy-oriented randomized trial that gets written up in the New England Journal of Medicine. Most clinical settings don't have that kind of money to provide that level of care. So it's really important to figure out what can get done in more of a community-based setting. But in order to figure out whether the result is due to the fact that your intervention didn't work or the fact that they didn't get the care that you think they're getting, you really have to collect these other data to be able to interpret it and figure out exactly what it's due to.
With the alcohol treatment, was the treatment the same that like a 30-year-old would get? Because, I really we all work in the field with the elderly and don't feel like the treatment that's out there for alcohol abuse is really effective for the elderly.
Well, what,
Repeat the question so Mason can hear.
sure. Is the treatment that's out there for alcohol misuse, at-risk alcohol, is it effective for the elderly?
Or in this study, is it the same treatment that like a 30-year-old we did, or was it more designed for those people that are 65 and older?
This was basically the brief alcohol intervention for 30-year-olds. This was a brief alcohol intervention for, and I'm not sure. I don't know what the exact. I don't know what the modifications were for. But I know that Dave Oslin and Fred Blow actually have a book that is evidence-based treatment for alcohol, for at-risk alcohol in the elderly. I think it's published by Springer Press in New York. I seem to think from what they say is that if it's delivered, I mean, you know, it's the fact that most people don't get it. But I mean, these data did show that there was a reduction if they got some kind of treatment. Is that what you're working in, is alcohol treatment?
No,
Oh.
we work in social services. But usually, like, you know, a 28-day inpatient stay may be effective for a 30-year-old, and it's probably not going to be effective for a senior citizen who's been an alcoholic for 30 years.
Yeah. I don't think we saw those people. I think these were people in primary care. These were people in primary care who were, you know, engaged, that were going to their doctors, that I think that it wasn't at that severe a level. So I don't know the answer to your question, you know, in terms of that group. I don't know.
Clearly, your study supports the integrated care model as well as
Absolutely.
the
Right.
model, particularly for depression. And there are a lot of areas where this integrated model is becoming, a lot of people are very interested in it. And so number one, I'd like to thank you for your article that supports that model, that we clearly see as something that is beneficial. How can we translate studies like this into the actual occurrence of getting those types of integrated care systems actively working in communities, for example, like Kirksville?
Well, someone at our meeting over lunch needs to answer. A lot of that has to do with the financial incentives. Where's the gentleman?
Repeat the question.
The question was, how can we actually get these integrated models implemented in community settings like in Kirksville, right? Well, I think Dr. McGovern did do that. Didn't y'all have an ElderLink? That was a model that, the problem is there isn't financial support for sustainability of those models. That's the problem. And there was someone at lunch who,
Mike French.
Mike French was talking about that, is that, you know, in the short term, it looks like it's going to even be harder to have those models because of the financial disincentives to have it. I mean, there was a financial disincentive that was really quite remarkable in this study. In the state of New York, a person you couldn't bill for a mental health visit the same day that the person had the primary care visit. So here you're at the primary care clinic, the primary care doctor says they walk them down the aisle to but they can't see the mental health person because they can't bill for the same day. It was the same here. So I mean, it's absurd. It's an absurd disincentive. Just an absurd disincentive. There was another one that was equally absurd at another state, and I can't remember which one it was, but the other disincentive was that, let me think. That was the on-site. The other one was, I can't think of it in a minute, but maybe I will. But it was equally as, it just didn't make sense. It was, I just can't think of it this minute. Maybe it'll come to me. But you know, that shows you that the finances they have to. Oh, I know what it was. This is what it was. that that a person could not, you couldn't bill for a mental health, you could, the master's prepared social worker or nurse could not bill for treatment, reimbursement, if the psychiatrist wasn't on site at the same time of the visit. So, I mean, the disincentives are just, they're huge. They're huge. And until, I know that one of the things that's going through now Congress is this parity law for mental health coverage. If that finally passes, that would be just, incredible. But that's a problem. It's just a real, and you were also, Dr. McGovern was also talking about another way of kind of integration, which was the flip side, is sending the primary care clinician to the mental health clinic. This is something that, So there are all kinds of ways to think about integration. There are all kinds of ways to think about that kind of model. But it really does come down to, finances, and it comes down to different, the physicians being able to work together and to talk to each other and to, recognize what different ways to collaborate and different ways to treat their older patients.
Okay, well, thank you very much, all of you, for coming. Thank you.
Thank you.
Dr. Epcot.
Thank you.
Thanks to our technical people in particular that did such a wonderful job, and thank you for being here. We'll take care of our